All right. Hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal. If you're a first time listener, welcome. If you have listened before, welcome back. And today we're joined by Mark Schroeder. Mark is the VP of Growth at Aroris Healthcare. Mark, thanks so much for joining us.
Yeah, thanks for having me, Eric. Glad to be here.
It's absolutely our pleasure to have you here. Before we get into the meat and potatoes of the episode, what else should listeners know about you and your work at Aroris?
Yeah, awesome. I'll share a little bit about my personal background first. Healthcare has been a kind of a big part of my life personally for forever, really. My dad's in the medical field, sisters are both nurses, so I've been seeing healthcare personally in that regards. And then professionally, I started my healthcare career on the payer side at United Healthcare. Spent 8 years over on the payer side, recently transitioning over to Aroris, which works directly with physician groups, filling that payer provider gap.
That's awesome. So you're there's nobody better versed to talk about provider and payer relationships than you, maybe, and that's why you're here today. I know some of the things that we want to talk about revolve around reimbursement, private practice reimbursement, and its outlook for this year compared to last year. What are you seeing so far? I mean, we're 29 days into 2025, so there's got to be something that's changed.
Yeah, I mean, I think to be honest, 2025 is probably going to be another tough year in healthcare. There's a lot of key points that we need to target and help fix, and it's not going to be fixed by one party. It's going to take a team of people and different companies and payers and providers working together to figure it out. So I would say 2025 is going to be another difficult year in healthcare, but with the right partners in place, I think we can find some good solutions and get it back on track.
Yeah, and unfortunately for those on the provider side of things, the healthcare organization side of things, when that 2025 CMS final payment rule was published, uh, there wasn't anybody happy about that. I think there was a couple of bright spots depending on specific communities maybe you serve in a certain classification, like your FQHCs, CHCs, but it's never enough. It's not enough, and obviously CMS sets their rates themselves. Roris is dealing with private payers, that is. So when you say it's going to be another tough year, are there any reasons that you can point to specifically? Are there any notable specialties that are really up against it compared to years gone by?
Yeah, and I mean, I think it's going to be a tough year simply because the rise in cost for a practice to stay open, a surgery center to stay open, the cost of supplies, lights, staff. I mean, you name it, everything's going up, and the payers are typically slow to follow. So that's really the challenge that we're facing. Costs have gone up quite significantly for a practice over the last 2 years. And if we're getting 2 or 3% increases or even decreases from CMS, like you mentioned, it's not sustainable. So we have to figure out a solution. And it's really a lot of groups just might not have the resources that it takes to dig into those negotiations and look at their contracts in a way to find those opportunities. So really putting the power of data behind a group and some expertise behind it, whether it's new technologies that are out there to create them and make them more efficient. I think it's going to be important for groups to look at in 25 to find areas of success, whether it's increased revenue through efficiencies from an operational standpoint or new equipment. There's a lot of new stuff out there that can allow groups to capture some revenue if it's not coming from payer increase and reimbursements.
Yeah, and it's just like it's getting from bad to worse when you look at the macro landscape of being a physician in any care setting. Physicians are retiring way ahead of schedule and certainly support anybody's right to retire whenever they want. When you look at physician as an occupation, we already don't have enough. They're burned out for reasons that do include reimbursement, but a myriad of reasons: technology, too much administrative tasks, or too many administrative tasks. You can point your finger at a half dozen different things that across all of the surveys say are driving physicians away from the occupation, and that they're continuing to be up against the wall with reimbursement. This does not look like a very bright outlook for these independent groups. However, some viewed it as a bright spot, some obviously didn't. But in addition to that 2025 final payment rule that CMS handed down, we had a presidential election, within 2 weeks of that, if my memory serves. Do you have any predictions on reimbursement under the the second Trump administration, either short term or long term.
Yeah, I want to hit one more thing back on the independent practices.
Yeah.
It just, the comment that you made just around independent practices. And I know I don't want to make it sound like it's all doom and gloom out there. We need independent practices for a healthy healthcare ecosystem. I'm super passionate about it. And I would tell you just my experience from being on the payer side and knowing that side of the world, having a father and family who's in medicine. We need independent practices. If everything goes away and we can't seek care through an ASC or an independent group, our costs are only going to go up. So I think what we've seen is conversations from our negotiations from the payer side are they're more willing to listen, right? Because they understand that we need to make sure groups are getting paid fairly, so they can stay open. They can keep providing the quality care to the patients and members that's expected. Their time shouldn't be focused on going through data and going through negotiations. And our average negotiation is about 80 to 100 touch points with a payer, multiple proposals, multiple phone calls. And if it's usually on a CEO or a physician to negotiate those contracts, they have a lot of other things on their plate. From a physician side, they're paid to provide care. That's where their time and energy needs to be focused. So finding partners out there that can help you, whether it's through technology or a company that can help with reimbursements, I think is going to be a vital part to the success of independent groups.
Couldn't agree more. We're flying the flag high for independent practices here at Doc Buddy. And as you point out, for the broader healthcare ecosystem as a healthcare consumer, and we all are, or we will be at some points, we need independent groups. Absolutely. Couldn't agree more there. So glad that you pointed that out. And then looking at this new president or second go around for an older president, is there anything on the radar, good, bad, or ugly, in terms of reimbursement for our independent practices?
Yeah, nothing that we're seeing. It's early yet, right? I don't think we're going to see any changes or anything that's happening right away in 25. But there might be some little things that are implemented throughout the time, and what you're going to see is depending on what gets passed from the new administration, the payers are going to take a look at that, whether they're looking from making changes to an overall contract because of some new policies that might get put in place, or it's a more of a heavy focus on value-based care. I think value-based care has been something that's been a buzzword for 20 years. It's something that makes sense if it's implemented the right way for groups, but we have to make sure we're tracking the right metrics for that. So I think what you'll see is, depending on what policies get passed, the payers will start making some changes through contract language or just through focusing more on value-based care, different reimbursement methodologies.
Yeah, you're right. It is still early. A lot remains to be seen. And for folks that want to hear a little bit more about broader healthcare policy in the U.S. related to the Affordable Care Act, also known as Obamacare, and some of the bigger, more macro points that affect all healthcare consumers, we've got an episode with Scott Becker from December, and then check out Mark Ryan from mid-November on our feed. But Mark, we've kind of flirted with it. These independent practices going up against the machine. And obviously, we need all parts of healthcare to coexist together: the patient, the provider, and the payer. But you painted that picture of an independent group or practice CEO or lead physician, maybe they're the same person, getting a large PDF in their inbox. You need to go through that, read it, figure out what could be better. What do I need to do to get the best rate for my group? What happens if they can't do that? Either don't have the expertise or don't have the time.
Yeah, I mean it's why Aroris Health was created, right? We were created because we fill that payer provider gap. We sit in one lane. All we do is work with physician groups, surgery centers, hospitals, and negotiate contracts with the insurance companies. When you have a practice that doesn't have the resources or staff, and it falls on a CEO's plate or a physician's plate, the time and energy it takes to negotiate a fair contract, you're not just negotiating rates. A lot of times you're looking at language of the agreements too. Maybe your contract's 15 years old and you have a couple amendments throughout the way. If you're not looking back at the full agreement, you could be putting yourself at risk through language of your agreement as well. So not just focusing on your rates, but focusing and taking a look at that full contract is something that's super important, that you need to make sure you're looking at. From the reimbursement side and the codes, if you look at an orthopedic group that's billing out a couple hundred codes, um, if you get a 3% proposal from a payer, you need to apply that to the specific utilization of the practice to see what kind of impact that's going to have to the revenue. We see it time and time again in our business where it might take 6 months or 4 months of negotiating from the practice side to get to a 3% increase that they've been able to do on their own. If you take the word that it's a 3% increase, it might not be to revenue, simply because of where the increases are happening on the fee schedule. It might be an aggregate to the full fee schedule where you're getting a 10% increase on a surgical code. You might do 10 surgeries for a year, and a 10% decrease on some E&Ms that really drive the revenue for the group. So it's super important that you make sure that you're applying the proposal that you get from the payer directly to your practice and the utilization, so you know what kind of revenue impact it would have.
Well, I want to go back to something you said around contract language too, and as specific as you can be. What are some of the common gotchas if it is a 15-year-old agreement? Couple of addendums, couple of adjustments along the way. Where does that trip up practices, or what kind of things trip up practices?
Yeah, there could be something as simple as bundling, withholding a lease network in there, just something to pay attention to in that regards. But again, there's a lot of, a 60 to 90 page agreement. You need to make sure that you're looking at kind of those key sections, to make sure that nothing's in there around that's going to affect the reimbursements and how you're actually reimbursed.
Well, and that's why we're here talking today. If you're one of these unfortunate either groups or practices that doesn't have the bandwidth or just takes the first offer, what happens to that type of group compared to their peers? I imagine they fall behind to some degree.
Yeah, I mean, I alluded to it a little bit ago, and by not doing the analysis of what the impact of that increase would be, and a lot of times what happens is if it takes again 3 or 4 months to get to a certain 3%, 4% price point, a lot of times they're being signed because they just want to get put in place, and the renewal date's coming up, and we just got to get this finalized so we can go back to practicing care. Or as a CEO, you can go back to making sure that the practice is running efficiently and you're doing everything that you need to do on that end. So the impact can long term have a major effect on long term revenue, because if you're leaving, you could be 15% behind market. If you don't know where market sits from a data standpoint, and where your proposal should be, maybe a 4% increase, you're still 15% behind market. So we need to be going back for more.
How would somebody know that? Is there open source data you can look around and see? I mean, genuine question here. That may lead you into the core value prop for Aroris, but how would somebody know that, independent of you?
Yeah, the price transparency data has never been more available, right? It's out there. You can get it. The important piece with that is making sure that you can understand it. There's third-party partners out there that will make those machine readable files readable, or it's finding a partner that focuses in it. And what we do at Aroris, we're going to make sure that we're evaluating the proposals. We know where the market's at. We have 150 clients across 40 states now. So a really good understanding of, the uniquenesses to each specialty too, because that does play a factor. Multi-specialty groups, so just getting a better idea of where market should be at. There's multiple different ways you can look at it. Whether that's looking for a transparency partner that you can get some rates from it, or finding a third party partner that helps you negotiate your contracts, give you a better line of sight.
So that makes a ton of sense. I'm showing my ignorance there a little bit on the price transparency data. To go back to our example, you're this group that just renewed their agreements, and they're listening to this episode going, "Oh my gosh, we didn't do hardly anything. We have a really small Excel file that we kind of tooled around in, and it looked okay. Is it too late? What can they do?"
Yeah, I don't think you're ever too late. I hear it a lot where, I'll ask a group when I'm talking to them, when was the last time you negotiated your contracts? And then I don't even want to tell you, it's been 10 or 15 years. And I was like, look, it might have surprised me in the beginning when I came over on this side talking to physician groups, but it doesn't surprise me anymore. And it's not something that is necessarily a terrible thing. You know, we can make up some ground from it. Um, but yeah, it's important that you put a focus on what you're getting reimbursed. You know, that's how you're going to make your money to, you know, continue on with the longevity of your practice and continue to provide that quality care. So making sure you're being reimbursed appropriately, super important. But if you haven't done anything, don't feel bad about it. You're not alone, and there's people out there that can help.
And in that instance, is there, and just speaking in generalities, obviously, we just renewed with United, and we have a Florida Blue contract coming up next month. If you already know what you got from the first payer that you already signed isn't probably what you should be getting, is there any recourse for a practice, or do you need to wait until the next renewal term?
Yeah, a lot of times it depends on, you know, is it a single year deal? Are you in a multi-year did you sign a 3-year contract? If you're in a 3-year contract, um, it's not guaranteed that you're going to be able to get out of it. But there are ways that we could work around that, and try to have that conversation and open that conversation up, either with an amendment to the contract or some unique strategy that we could possibly apply to try to make sure that we can get ahead of it before the 3 years are up, but not necessarily guaranteed that you'd be able to get out of that. Which is why it's important to make sure that you're negotiating your contracts and that they're in the best interest of your group.
Yeah, that makes sense, and certainly don't want to put words in your mouth. I'm just taking a stab at this. Obviously, I'm on the physician workflow side, not on the reimbursement negotiation side. I would imagine if you have a recently signed renewal and it just is not going to get you into black numbers, you know, you're going to be taking a loss when you factor in like keeping the lights on, as you said, FTE time, supply costs, all the way down the line. Is there a way to go back to the payer and say, this is a mistake, you know, after further analysis, these rates are not sustainable and you're going to lose me because I will be closing my doors or selling to the health system if we don't talk about this?
Yeah, for sure is a strategy that you'd have to play. Now, it's not going to be guaranteed that the payer will, you know, accept that as, you know, okay, let's open it back up for negotiation. But I hope with, you know, they understand the value that you're providing to their members in the area and, you know, showing real examples of, hey, look, here's the deal. You know, if you can show the cost of either what you're saving for doing it if we're talking surgery centers, you know, the cost savings to do the service or the surgery in a surgery center versus a hospital, significant savings to the payer from the payer side. So, you know, if you're like, hey, look, here's the deal. If I don't do something here, we might not be around in a year or 6 months to continue to provide the quality care that we are to your members. And if we go away, then the care is going to be done in the hospital. Now, I don't think there's anything wrong with care in the hospital, but looking from a member perspective or a payer perspective, it's cost savings to do it in a surgery center. So keeping that open and keeping them not just surviving, but we like to say thriving, right? We don't just want our groups just barely getting by and just surviving. You know, it's how do we get you to thriving, growing, expanding, you know, continuing to open up access to more members. That's really what we strive for.
Well, that underlines the point that it's really never too late. You might not get the answer you want, but the answer is no if you don't ask.
Correct. Exactly right.
So one of the things I'm curious, Mark, what are some of the things that you hear from groups that you work with or groups that you want to work with or not working with, any group, I guess, where they're telling you, oh, we just went through a great negotiation with this payer. Tell me more about it. And really, it wasn't a great negotiation. What are some of the common ways folks can get tripped up? And I think you might have hinted at this with looking at the volumes of the codes and the increases in the fees for each code and how many are you actually doing? Like a 20% increase on a code you bill 10 times a year doesn't really move the needle.
Yeah, I mean that's exactly it. You gotta look at it and apply it to your actual utilization. And a lot of times, you know, we hear it from groups where you know they feel like they're in a good spot, they're doing well, but compared to the market, they're still behind, right? So I would even say even the best payer that you have, the payer that you're getting reimbursed the most for, there still might be room to move that up. alongside working those other payers to a higher price point. And let, even if, our model and philosophy is, if a payer is reimbursing fair, we won't touch it. That's fine. We want to make sure groups are getting paid fairly. We're not going into a negotiation trying to take advantage of the payers at all. Our job is to strengthen that relationship between the payer and the providers and make sure that groups are getting paid fairly. So if we can lift another payer up to a higher price point, it allows us to create some of that leverage. So we really dig in and focus and try to figure out, where the areas of opportunities are. You can learn a lot just by, you don't need transparency data to understand where the opportunities are in your contracts either. You can evaluate and take a look and just see where current reimbursements are amongst your fee schedules. If you're a orthopedic practice and you're billing out, let's say 20 codes make up 70% of the revenue, focusing on those 20 codes amongst your contracts, your top 3 or 4 contracts that are again going to do 70 to 80% of your revenue. And you can get a pretty good line of sight to, hey, look, my 99214 with UHCs at reimbursing at $250 a unit, but my 99214 with Blue Cross is $50 higher. So right there is a gap that you can leverage through that negotiation. So even if you're billing out a ton of codes, it's really honing in on those specific codes that drive the majority of the revenue, and then those main revenue driving payers that can really help put you in a better spot just looking internally.
That's really logical to me, but we're talking about two things most healthcare organizations don't have, which is time to do this analysis and then somebody that's comfortable actually performing the analysis. Kind of a unicorn. If you can even make the hire, finding somebody that has both of those things. I guess the one thing, the expertise, is a part of their job. They have the time.
Yeah. Yep.
So that all makes good sense to me. In terms of some of the other snags that you see folks overcoming, what are a couple of recent either big wins or notable anecdotes for the listeners out there?
Yeah, I mean, a recent case study that I like to talk about goes right back to what we were just chatting about on reimbursements and how it applies to the actual revenue of the group. A payer came back to one of our groups and clients of ours and said it was an 8% increase, and any group would be like, "Where's my pen? I'm going to sign it now," right? It sounds like a great deal. When we ran it through our analytics, if they would have done the same volume as they did the year prior, it would have actually been a 1.2% loss in revenue because of where they were applying the increases and decreases on their fee schedule and what codes mattered to them. So we flipped the script on our negotiation and applied an 8% increase because we knew the payer was willing to obviously give an 8% increase. So we just gave increases on the fee schedules to the codes that mattered to them that added up to an overall 8% increase in revenue, and it was accepted.
Wow.
Now, they're not all going to go that easy or quick, but again, if the whole point of bringing that case study up is you have to make sure that you're looking at the data, because if you're not looking at how it applies to your actual practice, you're going to be leaving money on the table.
Yeah. Well, and one of the other things I'm curious about, Mark, is that the provider and payer relationship is generally at best adversarial and borderline hostile a lot of times. And in my experience, when you go back to the payer and say, we really need to talk about this fee schedule you're proposing, it doesn't work. It's not enough. And here's why. What do you see happen to that relationship between the payer and the practice or the facility going forward?
Yeah, I will tell you the way, data is important, right? You have to have strong data to be able to back, why we're asking for a 15% increase. But more importantly than that, it's building that story behind the data. What are you doing from a quality standpoint, access of care, cost of care? What are you doing to help build? Why does that payer want you and need you in their network? So making sure that when we come alongside our group, we don't just look at the data. We truly get to understand who our groups are in current state. We also want to understand future state, which I think is super important when you're looking at a negotiation. if you're a growing and expanding practice and you want to come into a new specialty line or a new service line that'll be billing out new codes, you should probably get on that sooner rather than later. So you're negotiating those codes in advance to get them to a fair price point. But I think it's super important in a relationship with the payer. One, you got to get to the right person at the payer. That's one other tough task to try to get to is the right person on the payer side that's going to listen to the story, right? You gotta be talking to somebody at the payer who understands the importance of having a good quality provider in the network and not losing them.
Mark, when you look at the earnings reports from the commercial payers, as a layperson, I'm sure friends and family ask you like, "Oh my gosh, they're printing money. They're making money hand over fist these commercial payers." So now you're negotiating on behalf of the practice or the facility or the group or whatever the case may be, getting more money for the provider. Is that going to hurt me, the healthcare consumer? Am I going to have to pay more? How does that dynamic work out?
Yeah, it's not something that we've seen trickle down, right? I mean, again, there's been record profits reported from the payer side for years, right? It's not something that negotiating a higher price point and moving a group up 5 or 10% is trickling down to what the members are actually paying.
Right. Right. And that kind of goes back to one of the earlier things that we talked about is that there's three legs on this stool: the patient, the provider, and the payer, and they all have to coexist. And that independent practice dynamic is so critical for healthcare in the US. I view it as a net benefit. We're very obviously not paying providers enough as a whole, like as the system, right? Whether it's CMS, commercial payers, physicians are retiring in droves. I mean, we're on the brink of a precipice that the mainstream news isn't reporting on yet. They will be. There are not enough primary care doctors or physicians of any specialty in the US today. What happens when you drive them all out over the next 5 years? Who's going to provide your care? How long do you want to wait for a physical? It's just insane.
Yeah, it's a major issue. I mean, my dad being an anesthesiologist, it's how do you attract new physicians? The pool is getting less and less, and if there's nobody to pull from, who's going to provide the care? Again, I think we're seeing physicians retire early. Is it the burnout from COVID and the multiple shifts they had to pick up because they didn't have the staff to do it? Probably plays into it, but also um, all the different issues they're having, the administrative burdens that they're having to deal with. That I think a lot of it can be it's not needed. A lot of it might be unnecessary, but there's I think many factors that we're seeing here. But yeah, we need to attract people into the medical field. Um, we can't have I don't want to have to call my pediatrician and look when I can get my kid in for a 7-year well visit, and it's like, well, 4 months scheduled out. Well, if we lose providers, it's going to continue to go up, and that's no good for anybody.
No, it's not. That 7 year well visit will be a 7.5 or 8 year well visit.
Yeah.
8 year old child for a 7 year well visit. It's unfolding in slow motion. I've asked a lot of guests that are way smarter than me on the show, if you had a magic wand, what would you do to fix it? And it's 100 little things building into this one big thing of wanting, having an attraction to becoming a doctor, entering into the field of medicine. So if you have a magic wand to fix this problem, I'd love to know what it is.
Yeah, I mean, again, you gotta. If you're passionate about healthcare and providing the care, it's you got to get it out there that whether you're at a system or you're at an independent practice. I think it's some of it falls maybe back on the practice to get out there and do some marketing and get out in front of people. And how do you attract them into healthcare? Because there's a lot of people that I think would be great in the medical field that just don't end up going into the medical field, whether it's because they don't want to go to 12 years of school or whatever it might be. Um, we got to find ways that whether it's shadowing or some programs that we might have to set up that I think might be important to help attract the right people into healthcare to continue to build up that pool.
Lord knows we need them. And one of the things you pointed out was around administrative tasks, the bureaucracy. Over the last 18 months or so, there's been an explosion in AI products, solutions. Some, I think it's debatable if they're actually AI or not, but a lot of tools claiming to be AI in healthcare. We're still very early for this AI craze in healthcare, but what are you seeing? Where do you think we're going? And is it good or bad?
Yeah, no, I think used in the right way, it's good. I think again early on, right, and finding products and solutions in just around technologies for practices. I think it can really create some efficiencies that weren't available before. Um, whether it's around, I've seen it in radiology where there's some AI built into it where it kind of pulls out some areas that a radiologist should focus on a case. So it reads cases quicker. It gives the radiologist an area to focus on. Now you're still having that touch from the radiologist to look at it, but I think, that's just one area that I've had a recent conversation on. There's multiple other clinical efficiencies I think that AI can help with, but it needs to be done in the right way for sure.
Yeah, that's kind of where I stand. The right way. There's a lot of tools out there all of a sudden. Some of them being LLMs embedded into EHRs. As a guy in health IT, I think that's pretty cool that we're doing that. But as a patient, and I'm certainly not an expert, but have kicked the tires quite a bit on these LLM products. I kind of wonder what will take a provider less time. Letting an LLM or some sort of generative text software create the documentation, which they then have to review, or if you, as the provider, just do the documentation yourself, which one takes less time? I think it remains to be seen. We'll see.
Yeah.
Mark, we've covered a lot of ground. Is there anything that we glossed over or anything you want to call out here?
No, I mean, I really enjoyed the conversation. I think the healthcare space, we've got a lot of things going on and a lot of things happening, and it's going to take a team of people from multiple different areas, both payer side, provider side. I think it's going to take a lot of people on the technology side of it to work together to really get us back on track.
Well, I'll tell you what, you handle the increased reimbursements, we'll handle better physician workflows.
That's right. I love it.
All right. Well, before we go, we got to be sure to plug your socials. Where can folks get in touch with you on social, your website? Where can people find more from you, Mark?
Yeah, you can follow us on LinkedIn, Aroris Health. You can find us there. We're posting, we try to post a lot of value added stuff to groups on what we're seeing in the marketplace. You can go to arorishealth.com. We've got a lot of good case studies out there. There's a contact form. If you want to talk to me, you can fill it out and I'll respond back to you and we can have a conversation. But yeah, happy to chat with anybody if there's any questions around anything related to reimbursements, contracts, just overall making sure you're getting paid what you should be getting paid.
Love it. We'll definitely get links to all of those places and sites into the show notes. And on behalf of the entire Doc Buddy team, I want to thank you for listening. Be sure you're subscribed on Apple Pods, Spotify, and YouTube so you always get the newest episodes of the show. Until next time, I'm your host, Eric. Thank you again, Mark, for joining us.
Yeah, thanks for having me, Eric.
We'll talk to you soon.
See ya.